Hello everyone. So today we'll be discussing about transient tachypnea of the newborn, or TTN. My name is Gifty Mkangala Julius, and I'll be taking you through this most common cause of fast breathing in newborn. So by definition, the transient tachypnea of the newborn is a self-limited respiratory distress syndrome, which is caused by a delayed clearance of the fetal lung fluid, and its incidence it usually occurs in approximately 3 to 6 per 1,000 term live birth, and it's usually termed as the most common cause of neonatal tachypnea. And its risk factor includes the twin gestation, maternal asthma or hypertension, late prematurity around 34 to 6 weeks, precipitous delivery, perinatal depression, gestation diabetes, macrosomnia, cesarean delivery, usually especially without labor. Pathophysiology and etiology of this condition. Usually the core problem of transient tachypnea of the newborn is on delayed clearing of fluids from the lungs. So normally there are some clearance pathway where the fetal's body in relation to the mother, this pathway usually helps clearing the fetal lung fluids which was previous there. One of it is through mechanical expulsion during labor, and another is through hydrostatic forces which are accompanied with the first breath. And another thing is usually at cellular levels the lung uses special channels and pumps like ENaC and sodium and potassium ATPase. Usually these special channels and pumps helps clear the fluids. So in transient tachypnea of the newborn, these channels usually may not work as quickly, so fluid stays in the lung spaces. So this extra fluids which stays in the lung spaces makes the lungs stiff and causes uneven airflow and reduces gases exchange, which leads to fast breathing. So usually the baby lungs are compromised, lungs compliance is reduced, the ventilation perfusion mismatch, and usually there is an impaired gaseous exchange, which leads to fast breathing or tachypnea. On clinical presentation of this condition, it usually begins minutes after birth, and the key features you see in these conditions are usually breathing rates which is over 60 breaths per minute, but also there might be some mild chest retractions or soft grunting sound when the baby exhales, but also sometimes you might see little blueness appears around the lips, but it usually improves with low levels of oxygen, usually less than 40% of FiO2. On auscultation, the lung sounds are usually generally clear without crackles or wheeze, and the blood tests usually rarely show high levels of carbon dioxide or severe acidosis. And as I said, most of cases of this condition resolve by themselves between 1 and 3 days of life. On radiological finding of these conditions, usually a chest X-ray helps confirm the diagnosis. So the key features on chest X-rays usually include a sunburst-like pattern of blood vessels near the center of the lungs on the perihilar, but also you might see the fluid in interlobular features, the grooves between the lung lobes, and we might see the overinflated lungs, the mild hyperexpansion of the lungs, and the diaphragm usually appears flat, but also occasionally there must be some pockets of fluids around the lungs which are regarded as pleural effusion. So importantly to know that if you do not see a ground glass appearance or air bronchogram, which are usual signs of respiratory distress syndrome, so that might suggest that you are possibly dealing with transient tachypnea of the newborn. So these features of ground glass reticular pattern air bronchogram usually favors the diagnosis of the respiratory distress syndrome rather than transient tachypnea of the newborn. On diagnosis of this condition, the transient tachypnea of the newborn is usually diagnosis of exclusion, and we have to make sure that we rule out other causes such as respiratory distress syndrome, pneumonia or sepsis, meconium aspiration syndrome, persistent pulmonary hypertension, congenital lung anomalies, air leaks like in pneumothorax, primary serial dyskinesia, which usually presents with longer course and prolonged oxygen delivery, oxygen need. But the key clue is that this condition usually improves and is self-limiting over 1 to 3 days. So management is usually supportive care. So we have to keep the baby warm and maintain the fluid, but also give extra oxygen to keep the saturation above 90. But also if the baby has trouble breathing, we might use a nasal CPAP to help keep the airway open. But also we have to ensure that the baby is feeding well. If there's rapid breathing that makes oral feeding unsafe, we provide parenteral feeding. So we only also give antibiotics empirically if there are infection risk and if we identified the risk factor of infection. So on further evaluation, if the breathing issues are severe or unusual, let's get a chest x-ray and check for blood gases as well. But also in conditions, if there is no any improvement by 72 hours, we must reconsider the diagnosis. Maybe it's something more than the transient tachypnea of the newborn. Maybe we're dealing with respiratory distress syndrome or other diagnoses. So there are some experimental adjuvant therapies which are not proved yet, but are not proved yet to be used. But we have these inhaled beta-2 agonists such as albuterol, which usually work by upregulating these pumps, which helps hasten the fluid clearance. And early data upon use of these beta-2 agonists suggest shorter oxygen requirements, but all in all, further research is needed upon these therapies. So on prevention of this condition, we have to make sure that we avoid delivering the babies non-medically, avoiding non-medical indicated early delivery, but also would make sure that we would not rely on checking lung fluids in amniotic fluid to justify an early elective delivery. But also for preterm late preterm deliveries, a single course of antenatal steroids can help speed up the body's fluid clearing channels. But we have to make sure that we watch for low blood glucose in the baby, because these steroids usually have hypoglycemic risk to the baby. And just to summarize, the take-home points is the transient tachypnea of the newborn is usually common, usually mild and self-limited, and its key features usually include fast breathing, mild retractions, and characteristic X-ray findings. And its management is usually supportive with oxygen and CPAP if needed. Prevention usually focuses on avoiding unnecessary early deliveries, and we must make sure that we always rule out more serious causes and watch for full recovery by day 3. So thank you very much for your attention. If you have questions or cases to discuss, then drop them down there, then we can discuss. Thank you very much. Have a good day.